Good morning. Thank you so much for the opportunity to talk with you. So I'm going to be talking about painful ejaculation in theme with today's group of pain talks. So this is horrible for the patient, very much not pleasant for us, as Dr. King mentioned. When we see these patients on our clinic roster, I think all of us have a little bit of a response to these pain syndromes. But I think it's extraordinarily important for us to identify these patients, to acknowledge these patients. And I think the power of knowledge is not only therapeutic for both the patient, but also for us in the treatment of these patients. So we're going to talk about prevalence, etiology, and treatment options. This is going to be a very boots on the ground type of discussion. So hopefully you can take some of these little pearls and tidbits back to clinic in a very utilizable way. So prevalence, this is actually fairly prevalent. So 1 to 10% general population. Interestingly, and I'm unclear of etiology, and as are the papers, up to 25% incidence in men with BPH, 9% of men with history of prostatectomy, oftentimes with coincidence of bladder neck contracture, and highlighted here, 30 to 75% of men with chronic pelvic pain syndrome diagnosis. So I really think this highlights potential pathophysiology for a lot of these men. Symptoms can be anywhere from seconds to lasting days. It can be mild to excruciating. One of the things to keep in mind with these men is that there is associated suicidal ideation and execution because of chronic pelvic pain and ejaculatory pain syndromes. Again, not to dismiss these patients. So the way I think about this, and again, there's not a lot of guidelines to go about this. I think about this in direct cause and indirect causes. And this kind of helps me framework these patients and go through their workup. So starting with direct causes is much easier because they're very identifiable and we have testing that can elucidate this. So infection, UTIs, urethritis, either gonococcal or non, STI panels, especially HSV, I think both 1 and 2, but especially 2. Prostatitis, and then much less likely urethral stricture, but worth mentioning. The indirect causes, I think, are far and away the most common etiology of painful ejaculatory disorders. So pudendal neuralgias and chronic pelvic pain or pelvic floor dysfunctions, low back pain, spinal pathologies, as was discussed earlier. And then we get into a different group of diagnosis, so like interstitial cystitis. And here we're thinking about how are the neurotransmitters, how are the hormones, how are cortisol and stress factors influencing our structures in the pelvis in ways that we just really limitedly understand, but I think are crucially important for us to continue to investigate. Medications, imipyramine, clopyramine, fluoxetine, and venlafaxine are some common offenders that can cause pain associated with ejaculation. So vasectomy, here's a little sidebar. So I have a partner in my group, and he was very much someone that if he saw a pain patient on his schedule, he was like, Mendez, please take this patient from me. And I said, no, Dr. X, you need to treat these patients and understand. And Dr. X went through a vasectomy and unfortunately developed chronic testicular pain and some ejaculatory pain thereafter. And let me tell you, he went through every single treatment pathway, and his feeling of going from a disbeliever to an experiencer really shed light for not only, him and all the other guys in the office, but for myself too, to see, someone go from completely normal to experiencing these chronic issues and just feeling really hope and lost. So, just to take that with whatever it's worth. BPH, as I mentioned, with this association in post-prostatectomy. So the almighty pudendal, we discussed this briefly in the first lecture. Looking again here at the pathway of this nerve, really understanding where this nerve is going and why the pain distributions are what we see. So we're thinking about penile pain, testicular pain, anal pain, perineal pain, irritative voiding symptoms, urgency frequency, OAB, interstitial cystitis, pain syndromes with bladder filling and relief with emptying, very similar with these pudendal pathologies. And what we see with this nerve and its pathway is it's going to go anterior to the piriformis, and then it's kind of going to get squished with the coccygeus muscle. It's then going to go through the under the sacrospinous ligament, and then it's going to enter into Alcock's Canal. And in these locations, you can imagine, these gentlemen will complain with pain with sitting on hard surfaces, and we can see through this pain, with the nerve distribution, why that may be the case. Now think of an orgasm. Think of that rhythmic contraction of the muscles in the pelvis and the distribution of where this nerve is and its impingement between these pelvic floor muscles. And it can be quite, easy to understand how that may impinge your pudendal nerve. The nerve itself is a sensory, motor, and autonomic functioning nerve. So because of those different functions, it's also, we start thinking about the pathways of ejaculation from the sensory pathway, the motor pathway, and the autonomic pathway, how they start to overlap each other in pretty significant ways. So for the workup, thorough history. This can really paint the full picture for you, and you can probably get about 80% of the information you need just from talking to your patient. So duration, other symptoms, pain location, surgical history, low back pain, leg pain, sciatic pain, neuropathies, psychiatric history, anxiety, depression, things of the nature, stress levels at home, something's changed, medications, and social histories. Your physical examine the penis, feel the urethra, make sure there's no lumps, bumps, or masses. Look at the meatus, make sure it's not strictured or signs of BXO or narrowing. Look at the testicles, examine them. Check out the inguinal canals, make sure there's no hernia. Digital rectal exam, assess for tenderness, not of just the prostate, but the lateral side wall muscles as well. For clinical diagnosis, you're going to get your urine panels, hormonal panels, and STI panel. I do a hormonal panel in most of these men just to rule out low testosterone. There's actually, I think, quite a high incidence, but again, separate talk. Microgen and MDX testing for some of the more unusual pathogens, cystoscopy if there's any suspicion for urethral stricturing pathology, and then MRI. So how to help the patient? Probably the very best thing you can do for these patients is acknowledge that their symptoms are real. Whether or not you believe them or not, the patient definitely does. If we think about Dr. Gross's talk yesterday, that perception, this is their reality, and it is really affecting their day-to-day life. Many patients are written off as crazy. They're bounced from doc to doc because no one wants to deal with them. It can be years that they've been going through this. Many are told that there's no problem, it's all in their head, and that's when the infection testing is normal. And like I mentioned before, these patients can be suicidal and they can't act on it. So that validation of someone is listening to them and hearing them, even if you don't have the answer, can be really, really helpful in their disease state. So I usually say, I know this has been very frustrating for you and distressing, but here are some of the things that I think may be causing your symptoms and some of the treatments that may help. Educating them about that theorized pathway can be also very therapeutic in its time. So once cysto, labs, and urine studies are negative, I divide them into the two groups. If they have coinciding symptoms of pain in the testicles, perineum, anus, voiding symptoms, back or leg pain, I'm going to be thinking about pelvic floor physical therapy with evaluation and treatment, MRI imaging, and evaluation for interstitial cystitis in a diet and pathway for them if that is the case. If it's an isolated symptom of just pain with ejaculation, you're going to rule out a direct cause, such as like a medication or a toxin exposure. BPH, you can try an alpha blocker, post-prostatectomy, eval, and treat for a bladder neck contracture if present. So these are just some resources that you can use as handouts for your patients. They're home pelvic floor exercises. Not everyone has access to a pelvic floor physical therapist. Not everyone's willing to go, and not everyone can afford it. So these are just some resources that you can use for your patients. The bottom one is actually a website, which is extraordinarily helpful, and it has a support group that's associated with it. So my treatment pathway, education, acknowledgement, treat those direct causes, pelvic floor physical therapy, give them a handout with vetted sources, because not everyone treats men with pelvic floor. And if they're not they can't access or willing, handouts with stretches, symptom relief, antibiotics for their anti-inflammatory properties, anti-inflammatories themselves, neuropathic pain medications like gabapentin, suppositories and nerve blocks, and Alcock's Canal. And I would love to investigate sacral neuromodulation, as it has been shown to be beneficial in this field. And then the last one, not our favorite one, but frequent appointments, reassessing these men, it's amazing how much they will dramatically improve. So it's actually really therapeutic, not just for them, but for you too. Thank you.